Hello, I'm Dr. Carl Middleton. I'm the Interim Senior Vice President for Mission and Ministry, and I'm glad to be with you today. I will be speaking on ethical issues at the end of life. By now, your facilitator should have shared with you a case study that you experienced within your institution. The second thing we'll do this afternoon is talk about an ethical framework for making end-of-life decisions. And then the third would be, what principles can we gain from the Church's teachings, particularly the ethical and religious directives for Catholic health services? And then after my presentation, your facilitator will lead you into discussion, hopefully adapting and applying the principles to your case study. End-of-life decisions are profoundly personal. But it's interesting, the statistics show that there's been only a slight decrease in the number of patients that died in hospitals in the last few years. Still about 70% of the people die in hospitals. And people, these 70%, are more likely to receive life-sustaining treatments, spend time in the ICU in the final month of life, and still only receive hospice care 3 to 7 days before death. I've seen some statistics that says 65% of Medicare, the annual allotment of Medicare, is used for people at the end of life. Anyone who suffered a serious illness or loves someone who dies knows that that experience is profoundly personal. And the decisions that you make are profoundly personal. Without notice, and in most cases without preparation, a life-limiting or terminal diagnosis turns patients and their families into consumers of health care. How do we then go about making ethical decisions at the end of life? First, I must provide an ethical framework. The first theological principle that we need to consider is that God is the author of life. God alone has dominion over life. We basically share in God's creation. And when God gave us the authority in the book of Genesis to name the animals and the trees and vegetation and that kind of thing, basically God was saying we have the power over life and human life decisions. The second principle is that we are stewards of this gift of life. We must accept the responsibility for becoming interpreters of God's will in difficult situations. And historically, we have done that. We've had tough decisions to make about war. And for the first 100, 200 years of Christianity, there was a huge debate. And many of the Christians were pacifists, that it was wrong to go to war. Then we've debated and continue to debate today about capital punishment. Is it appropriate to take the life of another because that person has taken the life of someone else? There's the issue of legitimate self-defense. We basically authorize police officers and first responders and our military to basically take other people's lives when it is absolutely necessary. So, and then there's conflict of life situations. People that we call saints today, because rather than to worship a pagan god, they stayed true to the one God that they believed in, but yet became the main course for the lions in the Roman arenas back in 100 and 200 AD. So we're pretty experienced in making end-of-life decisions when you think of all those important examples. The third point is the individual is ultimately responsible for interpreting God's will for him or her with regard to the mission of one's own life. And that's why I say this decision is profoundly personal. Maintaining, and this is the fourth principle, maintaining physical And biological life is not the greatest value in terms of our Christian beliefs. We know from the scriptures that human life has its greatest meaning and fulfillment in terms of its relationship to God and other human beings. I quote from that famous passage from John, "Greater love than this no one has, that he or she lay down his or her life for others." And the last theological principle to form our framework, human life is not merely temporal, but is transcendent. Now, it is interesting. A number of us who go to church on a regular basis, and no matter what church we go to, the worship service has some dimension of the Nicene Creed or the Apostles' Creed. And in that they say we believe in life everlasting. We believe in the resurrection of the body. We believe in the communion of saints. And so what those words mean is that we are saying death is not the end, but it's the beginning. That it's not a separation. When we talk about the communion of saints, we're talking about the union of all people that have died and all people who are yet to come. And what Easter teaches us is death is not a tragedy, but it is a triumph. However, that is the profound theological framework that which you and I have inherited for those of us who call ourselves Christians. Now, where have we been in the past in terms of life-death decision-making? Well, we've used some principles that were taught in nursing school and medical education programs and that. And the first principle was ordinary means must be used, extraordinary means may be used, and then no positive means to induce death, such as suicide, physician-assisted suicide, and euthanasia are not morally acceptable from the Christian point of view. Now you say, well, how do we define ordinary means and extraordinary means? Ordinary means with all medicines, treatments, and operations which offer a reasonable hope of benefit for the patient without undue pain, expense, or hardship. And therefore, if we determined that it was ordinary means, then we were morally obliged to do that. Extraordinary means was medicines, treatments, and operations which cannot be obtained or used without excessive pain, expense, or hardship, or even if used, would not offer a reasonable hope of benefit. I remember when I was first starting out in my career as a theologian and ethicist, that quadruple coronary bypasses were considered extraordinary means. Today, thousands are done daily throughout, and they're considered, given the particular type of heart problem, they're considered would be ordinary means. And that's why people began to use these two, ordinary and extraordinary means, as two comprehensive pigeonholes where we want to then categorize procedures and this, and that's missing the point of what these principles were meant to do. The key is, what is the reasonable hope of benefit of me doing this or having this procedure? Now, in terms of ethical issues at the end of life, how do we interpret and who decides? Well, as I said, going back to ordinary and extraordinaries, some people take the popular, if we did a man or a woman on the street, it would be simple versus sophisticated procedures. In the medical community, it was standard versus what is considered to be experimental. And we theologians and ethicists say what offers proportionate hope of benefit for me. And in the past, it was the physician who predominantly decided in consultation with the family. And as we know today, that has changed. Now, today there's a lot of talk, especially when it gets to end-of-life situations. What is the quality of life? And say, well, so-and-so doesn't have quality of life. Well, what does quality of life mean? Do we define quality of life based on physical means? Well, what do you do with the babies born that were affected by thalidomide back in the late 60s, and they were born without arms and legs and stuff? Do you define quality of life in terms of intellectual? Well, what do you do with people with 40 or 50 IQ? Or sociological? What about the homeless and the misfits? Is that sufficient? Or do you define it on moral grounds? Should quality of life even be a determining factor and enter into end-of-life situations? The late Father Richard McCormick, who was a theologian that taught at Georgetown and then at Notre Dame University, he basically tries to frame quality of life in terms of the meaning and purpose of life as a Christian. He says if the potential for human relationship is simply non-existent, or would be utterly submerged and underdeveloped in the mere struggle to survive, that life has achieved its potential. Now, what he was talking about, and he wrote a very famous article in America Magazine, what he was talking about is in the case of newborns who are born with gross multiple anomalies and maybe genetic anomalies incompatible with life. And he compared and contrasted an anencephalic baby that had a partial brain stem or no brain stem, live a few hours or a few days. He said, therefore, we bond with them, we show them love and that, but we don't do any kind of heroic measures, but we keep them comfortable. And we show them care and love. And he contrasts the anencephalic with a child born with Down syndrome. Can a Down syndrome child receive love? Yes. Can a Down syndrome child give love to others? Oh, absolutely. And I think all of us know, people, children, and now adults that suffer from or experience Down syndrome. Obviously, we would not then terminate the life of a Down syndrome baby, which some people were tempted to do back in the 80s. So, where are we today? Well, today we've changed the language a bit from ordinary and extraordinary means. We're talking about proportionate and disproportionate means, but you'll find a similarity in the definitions. So proportionate means a person has a moral obligation to use ordinary and proportionate means of preserving his or her life. Proportionate means are those that in the judgment of the patient, notice how I emphasize those words, that in the judgment of the patient offer a reasonable hope of benefit and do not entail an excessive burden or impose excessive expense. Get this, nor impose excessive expense on the family or the community, and that would include your local hospital. So what is disproportionate means in comparison? A person may forego extraordinary or disproportionate means of preserving life. Disproportionate means are those that in the patient's judgment, again, notice it's the patient doing the decision making here. Competent patient, I'll explain that in a moment. The patient's judgment do not offer a reasonable hope of benefit or entail an excessive burden or impose excessive expense on the family or the community. And yet, we find so many people in our hospitals, in our ICUs, and our CCUs saying they want everything done at all costs. There's a difficulty with that because we're limited in the amount of dollars we had. And then there's another principle here, withholding or withdrawing of nutrition and fluids, which is in the Ethical and Religious Directives, number 58. And I quote, in principle, there is an obligation to provide patients with food and water, including medically assisted nutrition and hydration for those who cannot take food orally. This obligation extends to patients in chronic and presumably irreversible conditions. For example, the persistent vegetative state, who can reasonably be expected to live indefinitely if given such care. Medically assisted nutrition and hydration become morally optional when they cannot reasonably be expected to prolong life, or when they would be excessively burdensome for the patient or would cause significant physical discomfort, for example, resulting from complications in the use of the means employed. And I'm still quoting. For instance, as a patient draws close to inevitable death from an underlying progressive and fatal condition, certain measures to provide nutrition and hydration may become excessively burdensome and therefore not obligatory in light of their very limited ability to prolong life or provide comfort. Now, what are we really talking about here when we talk about proportionate and disproportionate means and withholding nutrition and hydration? First of all, if you can imagine a scale, and on one side of the scale, you're weighing the benefits of a particular procedure or course of treatment versus the burdens. And guess who gets to determine it is the patient. And if the patient determines that the benefits outweigh the burdens, then it's morally obligatory. If the burdens outweigh the benefits, then it's morally optional. You get the right to choose. However, there's a caveat. We said excessive pain, excessive expense on the family and on the community. So promised benefits must justify the imposed burdens. And what we're attempting to do in end-of-life decisions is to determine if the anticipated burden of an action is justified by the promised benefits. So in the traditional expression, you say, well, what's the burden and benefit? Life need not be prolonged if the means to prolong life are ineffective and contribute to grave burden. So what's a grave burden? Father Gerald Kelly, a famous moral theologian back in 1951, said, a burden is anything the patient says it is. He didn't use exactly those words. But grave burden must consider social, psychological, spiritual, physical, and financial. All of those can be a burden in terms of end-of-life care. Well, how do we go about making these decisions at the end-of-life care? Well, the first thing you need to have, and this is the criteria for decision-making, the first thing we need to consider is the clinical diagnosis and prognosis of the patient. And in other words, we need good informed consent. We need appropriate medical information. And we need being able to weigh the burdens, the benefits and the burdens of those procedures. I like to make a distinction between critical care and terminal care. So if we had an accident on the freeway today and was brought into our hospital here, and they were brought to the emergency room and they had severe brain damage, they would probably go into cardiac arrest. And your emergency department team would grab the crash cart and go to work and try to resuscitate that person. What would be their intention for resuscitating the person? To prolong their life. Why? Because we don't know. We haven't done the workup. We don't know to what extent the person has suffered critical injury in that. And we wouldn't certainly know the prognosis. Now let me contrast critical care with terminal care. In the same ED, a patient arrives, end-stage pancreatic cancer. The extremities are blue. There is kidney failure, renal failure. There is pneumonia in the lungs. And a first-year nursing student can tell you the person's dying. The death process has begun in that person. Well, if you grab let's say they go into cardiac arrest, I'm going to submit to you that if you go grab that crash cart for that patient dying of pancreatic cancer, what are you doing? I would submit to you that your purpose for getting that crash cart is to prolong death. From our belief and from the framework and the principles I've shared with you, we're never morally bound to prolong death. So who decides this? Well, today it's the patient's informed judgment. And I quote from Ethical and Religious Directives number 59. The free and informed judgment made by a competent adult patient concerning the use or withdrawal of life-sustaining procedures should always be respected and normally complied with, unless it is contrary to Catholic moral teaching. Then the criteria for consideration. These considerations include family wishes, family burdens, religious beliefs, costs, societal interests, extensive resources, hospital policies, and state laws. Now, there's a couple of other directives that we need to apply here. I think that would be important. I want to talk about what if the patient, we said it's the informed judgment of the patient, what if the patient is not competent, is not capable of making a decision? Now, it used to be competency was determined by a physician and asking the question what day of the week it is, where are you, and what have you. But today we've added another dimension to competency, and that is the capacity. The capacity, the capability of being able to receive information, understand that information, and then assimilate that information and translate that information into a decision. And I jokingly tell people that in some instances of our life, like me, I'm incapable of understanding the back of my insurance policy. So, but for the most part, that's why we've expanded the notion and into life decisions from just being able to say where I'm at and what day of the week it is to a capacity to make decisions. Now, some other things we have to consider in terms of being a Catholic facility is the Ethical and Religious Directive on Euthanasia. That euthanasia is an action or omission that of itself or by intention causes death in order to alleviate suffering. We can never condone physician-assisted suicide. Rather, the real focus and effort should be on palliative care and helping to meet mind, body, spirit care at the end of life. And obviously, there is the fantastic services of hospice that can help us. And it's in the 5 states that have thus passed physician-assisted suicide laws, we find that patients who utilize hospice very seldom take advantage of physician-assisted suicide. And so that's why it's critically important for us to help meet people's needs in the dying process by holistic care. And that's mind, body, spirit, and pain care. Some of the other end-of-life issues is determination of death, and the church says we need to use scientific principles for that. A great way to show love and care for others is to sign the back of our driver's licenses and to offer our organs when we no longer need them, to offer them to others, and they then basically prohibit the sale of human tissue. Now, what are some of the things we need to focus on? One, we should provide supportive care of the dying. And that's that mind, body, spirit care that I talked about. That use of life-sustaining technology should be judged in the light of the Christian meaning of life and death that we talked about in the theological framework earlier. And that where there is true conflict or debates between caregivers and families, which sometimes occurs, we should refer treatments of doubtful obligation or conflicts to review by the facility's ethics committee. So I want to tell you of an experience I had for many, many years. I've been in ICUs and CCUs and stood at the bedside administering to people as they died. And there's this one case I'll never forget. There was 3 siblings in the family. 2 siblings stayed in town and took care of Mom and drove her to the doctor and taking her to buy her groceries and that. And Johnny, he ran away from home. And I don't know why they always go out to California. But here's Johnny out in California, and he hadn't talked to Mom in 15 years or so. And then the brother and sister calls up and say, Mom is dying. And Johnny then gets on a red-eye special and flies in from California and to, let's say, Minnesota. And so he gets there, and of course he's had a few drinks on the plane. And so he arrives there saying, I love Mom best. Well, you can imagine what the two siblings are thinking and feeling. And you need to step in quickly because war could soon break out in that room. And of course, Johnny's telling me he's going to sue and everything has to be done for Mom. And the two siblings are saying, no, we've talked about that. Mom has advanced directives. Mom made it very clear that she doesn't want this done. And that's an important thing to keep in mind if you're a surrogate and have to help other people make decisions. And let's say, especially if the patient is not competent and not capable, then you have to say, okay, to the surrogates, if Mom could make the decision, what would Mom tell us to do? It's not what Carl would do. That's not the issue. As a surrogate, it's I need to get in touch. Well, what is the value system of the person that I'm representing, and what would they choose to do if they could communicate that to us? That's most important. So what I do with the Johnnies of the world is take them to coffee, and I have them tell me their story. So I listen to the story, and then I said, come on, let's go visit Mom. So we go up and visit Mom. I pull up a chair. I have Johnny sit down. I put his left hand on her head and put his right hand over her hands, hold her hands. And I said, now, Johnny, you need to tell your Mom what you told me. So obviously, I said, it's documented that a lot of times the last sense to go is hearing. And so we're going to assume that Mom can hear you. And so obviously they break down crying and say, I'm sorry, Mom, and this. And at the right moment, what I attempt to do then come in and to say, Johnny, I'm sure if your mother could speak to you, she would say, Johnny, you're forgiven, and I love you very much. I said, but Johnny, love requires letting go. Your mother loved you so much, she let you go to kindergarten. She let you go to grade school. She even loved you enough to let you go to high school. Loved you enough to allow you to run away from home and to be apart for these years. Now, Johnny, you said you loved your mother. If you love your mother, you need to let go. Love sometimes requires letting go. And so as you minister to people that are dying, and when you see family members having difficulty, let them go. Remember the Johnny story and choose an opportunity to help share with them that if you really love, in the end, you have to let go. Thank you.